welcome again, everyone. It's great to have everybody here for our third annual conference. My name is Jason Booz. I'm an assistant dean here at the School of Medicine. I'm also a member of the Medical Education Research and Innovation Planning Committee. On behalf of the committee, I would like to welcome you to our third annual conference. This year, we have over 300 registered attendees, not only here in the state of Michigan, but from across the world. We also have nearly 100 scholars who are showcasing their works today. These individuals represent students, residents, fellows, staff, and faculty. Additionally, we have two internationally renowned scholars with us today, Dr. Ole Tankata and Dr. Lou Pangaro, who will be discussing cutting-edge science related to clinical assessment and instruction. Before we get into the heart of the conference, though, it is important to lay the framework for the research and innovations that are presented here today. Any modern field of practice is built on scientific foundation. Proverbially, we are standing on the shoulders of giants. As many of you know, medicine is no exception. We are in the midst of massive scientific breakthrough. The profession is constantly changing and adapting to these advancements. Whether it is the latest vaccine, non-invasive surgical procedures, diagnostic instruments, or finding more efficient ways to prevent diseases in our communities, scientific breakthroughs are all around us. In the same respect, so too are scientific advancements in the field of medical education. As a field, medical education has seen many changes over the years, from how we assess students to how we instruct them to even how we understand how they learn. Medical education looks very different than it did 20 years ago, for that matter, 5 years ago. We are currently experiencing times of tremendous advancement built on the foundations of scientific research and innovation. At today's conference, you will see some of the same topics being presented at the national stage, including diversity and inclusion, the science of learning, health and wellness, the opioid crisis, and where would we be with a 2021 conference without including information related to COVID-19 and how individuals and organizations are adapting. You will also see many cutting-edge topics being developed here at the Wayne State University School of Medicine. These include the empowerment of patients and the community, addressing the social determinants of health, patient safety and quality improvement. Of note related to these advancements is they are not coming from some far off ivory tower in distant lands. Rather, they're being developed right here in our own backyard. Nor are these advancements limited to those with advanced degrees. Rather, advancements in medical education, research, and innovation are occurring by those all around us. They occur by the inspired medical student who's not willing to sit on the sidelines as social injustices and continue to hamper our best efforts to create a just society. They occur by the resident or fellow seeking better ways of training and improving patient outcomes. They occur by the staff member continuously seeking better ways for us to learn. They occur by the faculty member seeking to adapt our curriculum to the ever-changing needs of our community. More importantly, though, these advancements are not occurring within these groups, but rather across these groups. As you listen to the oral presentations today and view the posters, you'll notice that many of our greatest innovations come from the co-development between learners, educators, practitioners, and the community. This conference is dedicated to these individuals in their pursuit of excellence in research and innovation. We're here today to highlight the many great works that these individuals have produced or are in the midst of producing. I would now like to turn it over to Dr. Schweitzer to formally welcome you to this year's conference. But prior to me doing that, let me point out a few housekeeping tips for everyone today. Participants, please stay muted throughout the event. And if possible, keep your videos off as well. However, please ask any questions in the chat box that you may have. And also, if you need to, you can relabel your name as well. And we also recommend using the speaker view for optimal experience. And as I turn this over to Dr. Schweitzer and then to Dr. Fulbert, our new Vice Dean of Medical Education, take a few minutes as we're getting settled in to share in the chat where you're zooming in from today. We love to see the great community that we've brought with us today. Thank you.
Thank you, Jason. Welcome to the Wayne State University School of Medicine's third annual Medical Education Research and Innovation Conference. It's appropriate that we take the opportunity to showcase the research and projects of our students, residents, and faculty, because our School of Medicine has always been a hub of such advancements. In fact, this very conference itself is an innovation, as we believe it is the first of its kind among the nation's medical schools. The Wayne State School of Medicine has been changing the face of medicine and medical education for more than 150 years and continues to do so daily. From the first open heart surgery to use a bypass device, to the development of the first approved drug to treat AIDS, our school has been a leader in medical innovation. We also embody this pioneering spirit in medical education, as evidenced by the first post-baccalaureate program in the nation, to our newest advance, a concurrent MD MBA program to be introduced to our class matriculating in 2022. Just as our faculty have always been innovative leaders, our students continue to explore and push to improve how we educate tomorrow's physicians and medical researchers. From creating programs that lead to hands-on seminars on patient safety and quality improvement, to educating fellow students on the opioid epidemic, as well as developing a plant-based nutrition unit into our curriculum. Our students steer education towards addressing relevant issues not found in textbooks or usual classrooms. An article published in the Journal of the American Medical Association in 1998 stated that medical knowledge doubled every 2 years. By 2020, that rate was predicted to accelerate to double every 73 days. I'd say even that prediction is not keeping pace with the reality, ingenuity, and inventiveness that remain key to advancing medicine and medical education. We all witnessed in real time the pace at which we were forced to learn about the effects of COVID-19. The pace of change and discovery will multiply so rapidly that we will be forced to not only keep up, but to determine what to keep up on. These advances will force changes and adaptations to the way we educate and the way we learn. And students who are at the forefront of newer technologies will be at the forefront of dictating changes in medical education. I join you in exploring some of these advances through the posters and presentations featured in today's conference. I especially want to welcome, thank, and express our appreciation to our two keynote speakers. Dr. Oli Tankata, Professor of Medical Education at the University Medical Center, Utrecht, and Adjunct Professor of Medicine at the University of California, San Francisco, and Dr. Louis Pangaro, Professor of Medicine at the Herbert School of Medicine of the Uniformed Services University of the Health Sciences. Thank you and enjoy the conference.
Thank you, Dean Schweitzer. I would like to now introduce our new Vice Dean of Medical Education, Dr. Robert Fulbert.
Thank you very much, Jason, for introducing me. I am so new that I'm here for less than a week at Wayne State, but thrilled to be here and working with the medical education team. This is such an important conference because it really permits all of us to learn from each other about what is happening here at Wayne State and to learn from esteemed, distinguished speakers in the field what is happening in medical education elsewhere. So I hope that today's presentation is a dynamic exchange of ideas. Wayne State University School of Medicine has always been a leader in urban health. It is now ascending rapidly in the basic sciences, and it's really a dream to see Wayne State University School of Medicine achieve a position as a masterpiece of medical education. This is one component of that. I wish this conference and all of its participants much success and a wonderful afternoon. Thank you, Jason.
Thank you, Dr. Fulbert. I would now like to turn it over to our Senior Associate Dean, Dr. Senthil Rajasekaran.
Thank you, Jason. My name is Senthil Rajasekaran. I'm the Senior Associate Dean for Undergraduate Medical Education and have the delight of welcoming you all for the conference. And I'm delighted to introduce the first speaker. And not often we have a research that causes a paradigm shift in the way we operate. We're really fortunate to have one such person who has graciously agreed to be here for you all today. Dr. Ali Tankata, PhD, he's a professor of medical education at the University Medical Center Utrecht, Netherlands, and the adjunct professor at the University of California, San Francisco. With a background in undergraduate medical training and a PhD in social sciences, he has 4 decades of experience at universities of Amsterdam and Utrecht with curriculum innovation, educational research, and faculty development in the health professions domain, both locally and internationally. He was the founding director of the Center for Research and Development of Education at the University Medical Center Utrecht, served as the president of Netherlands Association for Medical Education, and has published over 450 papers in the medical education journals and presented more than 500 times about advances in health professions education. And he has successfully mentored 24 doctoral students, and there are 9 doctoral students currently whom he supervises. For his work, he has received several awards, among which the J.P. Hubbard Award of the National Board of Medical Examiners, which I'm sure for those of you know, that's the highest award of recognition that NBME gives. He was the recipient of that, and the Ian Hart Award for Innovation in Medical Education, the NVMO Handmall Medal, and a Dutch Royal Distinction for his contributions to medical education are just among the few that he has been recognized with. One of his interests is competency-based education in health professions, and specifically in the application of entrustable professional activities and entrustment decision-making. And the entrustable professional activities, shortly called as EPAs, was first introduced by Dr. Tankata in 2005 to better connect competency to daily clinical practice. So with that introduction, I'm glad to hand it over to our first keynote speaker, Dr. Tankata. You're muted, Dr. Tankata.
Well, also thank you very much, Senthil, and we know each other, so I'm delighted to be invited at this conference. I will talk with you about assessment for entrustment in the clinical workplace using EPAs or entrustable professional activities, as Senthil just said. Issues to think about. So again, my name is Ola Tankata. It's always difficult to pronounce my name. Everybody does it a little bit different, but this would be the Dutch way, Ola Tankata, and from the Center of Research and Development of Education at the University Medical Center Utrecht in the Netherlands. Issues to think about. Just let's start with an issue to think about. Would you trust your loved ones to this trainee? And just think about certification decisions in postgraduate training. Now, some of you may be involved in postgraduate training. Have you ever had any hesitations when you signed off for completion of training for a trainee that you would say, well, I'm not really sure if I would trust my own family members with this person? So we actually, one of my PhD students did an interview study in Europe among program directors in anesthesiology. And he actually found that actually many residency program directors could recollect signing off for cases or of completion of training, even if they would not feel completely confident for that person, would actually hope they would not apply for a job in their hospital or not have their family members be attended. So you could call that a failure to fail. There's always many, many reasons for failure to fail. A dominant reason in postgraduate training, but also I would say in undergraduate training, is just the time is up. I mean, the program is ended, and you have no valid documentation or reasons to fail a person, even though you don't feel comfortable. Or failing a trainee will give you a lot of trouble. You know that you might just give a bare pass, or you say you would have no tools to handle it, or you have a rationalization when you are unsure you're for the benefit of the trainee, and of course implicitly not for the benefit of the patient then. So think of these questions, I think of the imperative of competency-based medical education. Basically, one way actually to summarize that is to reduce those false positive decisions when graduating trainees for unsupervised practice. And basically the essence of competency-based medical education is to have education that aims at a standard level of proficiency for all graduates. And what you then need is the clear features of CBME are a description of the standards of a good physician or specialist, and to make sure that you assess all medical trainees using these standards, and to have those standards of competence and not time in training as a primary reason to finalize that training. So competency-based medical education, we now actually kind of agree on the core components of it. Apart from the summary, the core components are, it is an outcome-based approach to training with progressive sequencing. There's tailored learning experiences, there's a competency-focused instruction, and there's programmatic assessment. And CBME has really been appreciated in many countries. My country has adopted a CBME framework 20 years ago. I was personally rather involved in actually doing that in the Netherlands, but many countries have adopted that. Most of them would do that with the Canadian model called KenMeds. Others have used the ACGME, the United States model. And basically people would say, yes, that's a good direction. At the same time, however, you can see in the literature there is some criticism. Frameworks can sometimes can become analytical and detailed. Competencies are sometimes rather abstract and general. And if you think of teachers, some teachers really struggle with assessment doing that. So there is a history to competency-based education that goes with ups and downs. And a reason why that's not always easy is, I'll try to show that in a few slides. If you think of the analytic approach that has been used for CBME, for competency-based education, just think of people who would say, well, I have to graduate a doctor that meets standards. But if you say meeting standards, you would probably need to break that down in some way. So why don't we break that down in domains of competence? Or the Canadians would call these roles, but basically they're somewhat comparable to the United States ACGME roles, or domains of competence, medical expert, collaboration, communication. So that would be more easy, people would think. But then if you just think of each of these, take the communicator, for instance, communication with nursing staff or with families or with patients or colleagues or trainees is actually different. So you'd probably, if you really want to make sure that people meet those standards, you would probably have to assess them on all those domains. But that's maybe not even enough. So after a while, with new generations of those frameworks, people would say, well, if you would assess communication with patients, there's a difference between breaking bad news, communicating with elderly or children, or just a consultation, or to explain medication. So what you can find, so after a while, and this is the third edition of the KenMeds Framework, 2015, it has over 700 elements. Now you can just imagine that just any clinician wouldn't, even in Canada, I mean, Canada is very education focused, but nobody would remember those, let alone that they would be able to make sure that everybody meets all those standards, all those components of standards. And basically, if you look at the literature, people would actually say it may not be the right approach to look at instruments or to develop instruments to assess competencies separately. And in a literature review, Stefan Luria 10 years ago already concluded that there's no evidence that the current measurement tools can actually assess competencies independently. And there's further efforts needed to be, are unlikely to be successful in that direction. So maybe use competencies to guide and coordinate evaluation rather than develop instrument to measure those competencies directly. So people were struggling. This is 10 years ago. Now, new elements have been added to make it more manageable. There's actually two big components that were added after these introductions. One is milestones and one is entrustable professional activities. Milestones, I will just spend one slide on it, and the rest of the slides go more deeply into EPAs. So milestones, as you know, are mandatory in United States graduate medical education since about 8 years. And what they basically do is give description of expected trainee behavior at developmental stages to guide monitoring of learner development. And EPAs, entrustable professional activities, now increasingly applied in undergraduate, postgraduate, and other health professions, are actually the concrete activities in healthcare that we're actually training for, to ground competencies assessment in things that are relevant for practice. So again, milestones, this is an example of milestones with 5 developmental stages: novice, advanced, beginner, competent, proficient, expert. Don't read what's on this slide, but just imagine there is a kind of a picture described for all those levels, and that makes it a little easier to say, well, this person is that at that developmental stage. And as you know, in postgraduate training, every 6 months, you have to report that about every resident. So that's milestone. I won't spend too much time on milestones, but now entrustable professional activity. Let's go back to the definition. What it basically is a unit of professional practice. And if I say a unit, you can think of it as a task or a responsibility, sometimes a bundle of tasks together. That would be that unit of professional practice. And that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute that activity unsupervised. So basically, that has been the definition 15 years ago. It still is the definition. And the purpose of using EPAs is to operationalize competency-based education. We feel it is not easy to apply that. And giving the tool of using EPAs makes it easier. It enables a stepwise and safe engagement of trainees in clinical practice with progressive autonomy. And to become competent, then, could it kind of be defined as passing the threshold that allows for sufficient trust in the trainee to act unsupervised? Now, if we think of EPAs, many people actually keep asking, what is the difference between EPAs and competencies? This slide summarizes that difference. It is basically a conceptual, completely different concept. So competencies are things that you cannot see on the outside, that things that people possess, like knowledge and skills and attitudes. That's what a person is able to do, a capacity that they have, expertise or knowledge or ability. And if you look at the Oxford Dictionary says it is the ability to do something successfully or efficiently. Now, EPAs is actually, if you go to that same dictionary, you could say that something that is being done successfully or efficiently or trusted to be done. And there's permission required for qualification to do that. So EPAs are really not descriptors of persons, but descriptors of work. You cannot possess an EPA. I mean, EPAs, the things that you can find on a working list or a personnel ad or the to-do list. So things that must be done. If you're directing a clinical department, there's a patient that must be discharged, or you need hands in the COVID ICU, or there's work to be done, and you're looking for people. If you don't have them, you'll have to you have to hire them, or you have to train them. So if you think of the EPAs that need to be done in your department, then they're looking for persons with a profile of competencies, that they need to have to be able to do that work that specifically is needed in your department. So the tasks or EPAs are really different concepts than competencies. So if you could think of two dimensions of a grid. So if you have on the left side, you have competencies here. Here are the broad domains. You could break them down in smaller subunits. But then you have the EPAs, things that happen in the clinical workspace from Monday morning, 8 o'clock until Sunday evening, things that must be done. And almost all those things, if you would think of a person doing that, requires an integration of different competencies at the same time. So if you are asking a person to do history, of course that requires communication skills and professionalism. But if you have no medical expertise, there's no way you can do a history. You don't know what next question to ask. You cannot come to a conclusion. You cannot really do that. And it's a little bit unnatural to disentangle that and call them different competencies and assess them separately. So their recommendation really is to focus on the EPAs. Can you do at the end of the day, you just want to make sure that they can do that history taking or a procedure or whatever other EPAs you can think of. And if you have a program that is mapped with EPAs and people actually can do all those work, you can just assume that they have the competencies that are needed. Use those competencies, however, to provide feedback. So if you are looking at someone, you think, well, this person is not ready to do this by themselves, then you can ask yourself, why is that? Is that their expertise? Is their collaboration skills? Maybe health advocacy? Can't they look up something scholarly if they need more information or something? So you might be able to provide them with feedback and say, come back tomorrow, we'll see you next time. And you want to see them integrated to do that EPA well. So basically you could say not so much working with EPAs, not so much an analytic approach, but it's more a synthetic approach. Things come together, it's more holistic. So each of these EPAs actually requires a combination of competencies. So now let's move to think of when is a person competent? And one way to define that is when a professional activity is mastered at the threshold level that permits trust to act unsupervised. So competent basically can be seen as a stage in a developmental continuum. So if this is the continuum, and from left to right is the time, and from bottom to top, that is the proficiency. You could say that people actually increase in their proficiency. We start as a novice, advanced, competent, proficient, expert. That's a well-known framework, Dreyfus framework from the 1980s. And nicely, you can see that the word competent, they actually project in the middle of that whole framework. And you could actually say a person in training at point X will be ready for unsupervised practice, which does not mean that they have mastered at the top of their ability, because if they are in practice for 10 years or 20 years, they're bound to be better if they keep on doing deliberate professional practice. But there might be a moment that now we think, our team thinks you are ready for unsupervised practice. And you can apply that to one EPA. There might be another EPA that's easier. And you have a higher level of skill at an earlier point in time. Or there might be an EPA that you don't start training until the second or third year, an easy EPA. And if you draw that line here, you can readily see that there's different moments that the learner would actually meet that threshold level. So there could also be different moments of justified entrustment decisions. So if you build your program with EPAs, there might be several moments in time that you could say, now you have actually met that criterion for this EPA, for that EPA, and you're ready for unsupervised practice now. Now, unsupervised practice, of course, that sounds like a dichotomy, supervised or not supervised. We know it's more detailed. Like, oh, here's another EPA. That's nice to look at, this one. Here, if you don't practice afterwards, you might lose actually our trust, and you may have to go back to have supervision if you want to take that up, if you haven't practiced that for 5 years. So, but I said there's different levels of supervision. We use a framework of 5 levels, very commonly used. Level 1 would be that the learner is actually permitted to be present in the clinical space, are not permitted to enact the EPA. So here, to practice the EPA with direct supervision in the room proactively, supervisor can take over if needed. That is already a significant next step. The third step would be no supervisor in the room. So we call that indirect or reactive supervision. That's actually where we want medical students to be at the end of training for most of that clinical work, be able to do it without our direct presence or direct supervision, but we are available. You are still doing things under supervision, and the supervisor can either choose to pop in or choose to wait until for a request for supervision. And then that threshold that I just mentioned is actually the threshold for unsupervised practice. So unsupervised practice, basically, I would say the level that you really want for every EPA in postgraduate training, people are really ready to work without any supervision. And if they progress in their proficiency, of course, they will be ready to supervise more junior learners. And that would, for an easy EPA, you could also reach that level if you're still in training. So look at this. So if you think of working with EPAs, you can just imagine that programs are much more individualized. So this is a postgraduate program, but it could also be applied to undergraduate in the last years. So if this is a trainee called Jones, there is 4 EPAs, there is 4 years in training. And you could see that for each of these EPAs, different levels of supervision, decreasing supervision, increasing proficiency can be reached. And that level 4 is the most significant decision made. And you can see that for EPA 1, that happens in the 3rd year. And for EPA B would be in the 4th year. Basically, this framework, actually, if you're building a program, you can just imagine that there is like a template that you use. But once you work with trainees, you have to monitor them, and you might find that in some respects they may be quicker than others or quicker than planned, and so you'll have to monitor and make sure that you really have observed enough to make that important summative entrustment decision that they are ready for unsupervised practice. So if you think of it in the same graphs, you could also think of shades of decreasing supervision. This is observation only. Here is direct supervision. There's indirect supervision. Here's distant supervision. You could say unsupervised practice. And even after that, so even people who have finished training are usually in an environment that they can still ask for help if really need help, or call someone. But important to think of it is a summative entrustment decision for unsupervised practice level 4 can be somewhere during training. Doesn't have to be on the last day of training. And basically, this is an important phase, the phase that people actually are considered you have already met the minimum requirements for that EPA, even though you're still in training, and we will actually treat you as a colleague rather than as a trainee. So if you think of entrustment decision-making, it might shift our thinking about assessment. So if we think of education traditionally, if you think of your own education, think of grade school, secondary school, maybe college, tertiary education. Usually what we think of assessment is the question, does the student show the mastery of the content taught in the courses and rotations? We give them assignments, we give them tests, and if they do those tests well, there's no reason for us to say, why should they get a high score? And they can complete the education with a diploma or a certificate because they have actually done everything that we asked them to do. Now, would that be enough for a person working in healthcare? Just think of it at a minute. At the end of training, at the end of medical training, specialty training, The most critical question is probably, is the student ready to assume the expected future responsibilities? So we're not only concerned with whether they actually did everything we asked them to do, will they also be ready to do the things that we have not asked them to do, but they will face in practice, which may be slightly different than anything that we have observed. Just think of that approach, and we call that a prospective vision on assessment. Not so much did they do everything we wanted them to do, but are they ready for future responsibilities? That's prospectively thinking of assessment. So if you think of the psychology of traditional workplace-based assessment, here think of a trainee thinking by themselves, please mark me as superior, and you would think, well, she's nice and she's working hard, and it probably will not hurt her and may likely motivate her if I mark her as superior. There's always good reasons to do things, and you just kind of feel, this is how people sometimes think, but how valid is it, and how patient safe it is actually? If you move to an EPA-based program, an EPA-based workplace assessment your thinking would probably shift somewhat. She is nice and she works hard, but can I trust her with this EPA? It may hurt my patients if I mark her as ready for unsupervised practice. That's a critical, important thing to think of. You think prospectively. Is she ready to take over from the work that you are doing? So think of trust as a concept in EPA-based assessment. Trust is actually trusting someone means you're making yourself vulnerable. That holds in healthcare or other domains too. And what you're actually doing, that passing threshold, is you're accepting the risk that adverse events could happen, but you're willing to accept that risk for that person. There's always something that can go wrong, but now you think this person has progressed enough that you're willing to accept that. So that's an important way of thinking when you think of entrustment decision-making, and have to realize that graduates will be certified for activities that supervisors have never observed. You just can't observe everything that's important. So you'll have to rely on information that is enough to make you trust that person, and realize that even the learners may not have encountered that, everything that's important. So entrustment decisions require an estimation of some sort of adaptive competence to cope with unfamiliar situations. And trust also involves more than an average of past performance. If we think of psychometrics of assessment, we usually think, well, why don't we take an average? So just look at this graph. So there's 10 performances of 2 learners. There's learner 1, learner 2. Learner 1 is the blue one with an average score on a it's a kind of an odd scale from -10 to +10. And you can see just 0 is, I would say is acceptable, and below that would not be acceptable. Above that would be acceptable to really outstanding. This learner 1 has an average score of 2.1. Learner 2 has an average score of 1.9. Now, who of those 2 learners would you trust tomorrow with a new patient? Would that be the blue one, or would that be the orange one? I won't give the answer. You can just think for yourself. Who would you trust most for the next patient? So you can just see that that prospectively looking and making an entrustment decision is not exactly the same as our traditional assessment. So if we think of assessment, we usually think Miller's pyramid, which is a terrific, iconic pyramid and very, very helpful in shaping our thinking about assessment. But you can also imagine, let me just say what we're doing here. For those who are less familiar, of those levels, of course, we're testing knowledge, we're testing applied knowledge to one level higher, the integration of knowledge, skill, and skills, usually in simulated situations. And at the DOS level, we look at the integration observed in the context, in the clinical workspace. Now, if we think of entrustment, we might think slightly different of that same pyramid. We might think of the same things, knows to does, but the trusted level is actually an estimation of the readiness for future demands, which is slightly different than just observing and looking at people and say, well, they didn't make any mistakes, so we can give a satisfactory score. No, they didn't make any mistakes, but will they not make mistakes tomorrow? Are you really trusting them? What is different? Are there other factors that you actually want to factor in that equation of trust? So if you think of what factors determine entrustment decision, just think of this. You're here as a supervisor and you have a learner, and you're just asking yourself, can I trust this student to attend to this patient now? And just think of, probably it's more than knowledge, skills, or specific proficiency that comes into that equation. So we call that ad hoc entrustment decision. And that ad hoc entrustment decision is simply the decision to leave the room and leave the learner alone with the patient. That's an ad hoc decision that you're taking. You don't call that a decision, but it actually is one. And you're in yourself, you just think of, can I trust this student to attend to this patient now? Think of that. Can I trust this student to attend to this patient now? We have enough literature to show that there's actually different components in such decisions. There is a trainee component, the supervisor component, there's a task component, there's a context component, and there is a supervisor-trainee relationship that all together in some sort of unconscious mix makes you make that decision. So there is trainee elements, and I'll come back to that in the next slide, so I won't go too in there. But the supervisor, think of some supervisors are easy, some are not so easy doing that. It depends on clinical experience, clinical ability, trust propensity, experience as a supervisor. The task, of course, is important. What is attending to the patient? What does it mean? How difficult is that task? What are the risks that are involved? Or the context is important. Is there other qualified personnel around? What is the time of the day that's important? Is it in a night shift, or is it during the day when there's many people? Is there need for hands? Of course, from the COVID pandemic period, we know we sometimes really want just anyone to help us, and we would make that ad hoc decision to entrust a person probably much more readily than if there isn't much more qualified personnel available. And of course, there's a relationship. If you don't know someone, it's difficult to trust them. So there's something of duration of acquaintance. There's like-mindedness. There is a culture in your department to trust other people or not trust other people. So there are elements that actually are involved in generating trust. What are those qualities? And if we look at different literatures, like not only clinical education, but also management of philosophy and sociocognitive trust theories, and look at those literatures, and we find remarkable resemblance in what people actually say are important factors in trust. It's things like having knowledge and skills, truthfulness, conscientiousness, discerning limitations. That's from one study of Tara Kennedy. But also the management layer, ability, benevolence, having integrity, or the philosophy literature about being competent, honest, reliable, showing vulnerability. Or there is even more formal theories, computational theories about trust, where they have predictability as a component too. But there are striking differences. If we just go to healthcare, we have recently summarized the literature about 10 studies in which the main question was, what are the factors that clinicians find important before they make a critical entrustment decision? Of course, it's capability, it's knowledge and skills, experience, awareness, and oversight, but it's also integrity, truthfulness, which includes in truthfulness, good intentions, benevolence, patient-centeredness. So if you're not truthful, if you don't have the right intentions, it might be difficult to trust you. So reliability is conscientiousness, predictability, accountability, to be responsible. If you don't show those features, it's more difficult to trust you. Humility is important. So that whole domain that includes observing your own limitations. If you're not willing to ask for help when you really need help, it's difficult to trust you. Are you receptive to feedback, actually? And agency is important. You need a level of self-confidence, some proactive attitude toward work, towards your team, toward patient safety, towards your own development. So those 5 components so far from the literature, we think, and there are other studies being done now to validate that framework, but it's a helpful framework to think about that. And it's not just if you're thinking, can I trust this person now to do that? It's those other elements that are also important. If you juggle the words around, you come to a kind of a nice acronym that you can remember. Think of a rich entrustment decision when you take all these components into account. Now, that was ad hoc decisions. So if you're really certifying persons, of course, at the end of training, there will be license, and of postgraduate training will be certification. But if you break that down into EPAs, there might be EPAs that you really want to certify or acknowledge or qualify a person during training. We call that summative entrustment decision-making. That usually those things are made by teams that are fed by important information that has been collected after, I would say, after many of those ad hoc decisions that are evaluated afterwards. Was that a right decision to do that? Did the student report well? Would you actually recommend to the team, to the entrustment team or clinical competency committee, that this person is ready for unsupervised practice or indirect supervision? And then a statement of award responsibility might be actually issued. And if you think of it as an educator, we don't do that in practice really, but just think of it. Are you ready to put your signature under this statement that this person for this EPA is now ready for indirect supervision or unsupervised practice? That's a critical decision. That's not easy, but it's a responsibility for educators actually to think in that direction. So if you think of that as a process, if you have many learners, many EPAs in programs, what you actually can see here in this diagram is that learners actually do practice EPAs in ad hoc situations. They're being evaluated, they receive feedback, and there's multiple times that they do that ad hoc. The information that can be collected after evaluation of those instances can be fed into a portfolio of the learner. And that portfolio information, that collective information, can feed into a clinical competency committee or an entrustment committee that actually decide, has this person really passed the threshold for unsupervised practice or a threshold for indirect supervision, and can we provide a star for that person? So back to that individualized workplace curriculum, there's some recommendations to that. So why don't we start evaluating a learner's competence profile from the start related to EPAs? Depends a little bit of whether this is undergraduate or postgraduate. In my country and many other contexts, people are not all equal when they start. They have different experiences. So it's really wise to look, where would you expect them to get those stars? Plan those at reasonable moments and monitor then trainee to adapt the plan if needed, to invite them to apply for stars. So learners should also own their own curriculum to some extent. They should be active, proactive actually in thinking, I think I'm ready for this now. Can I be observed like a final time? And can I be actually be qualified to do this with only indirect supervision or unsupervised? And to make sure that training increases in responsibility and autonomy. So finally, I have some additional things to think about. And that the first thing is actually to avoid entrustment decisions that are not entrustment decisions. I'll explain that in the next slide. And then not all objectives of medical education training can be captured in EPAs, and think of finally also about technology to support competency-based education with EPAs. So if you're making entrustment decisions, I've seen programs actually using that terminology, would say, well, here's a scoring form. Are you ready for it? We'll sign off for entrustment, for an entrustment decision, and then nothing happens afterwards. Well, actually, you're not using the power of EPAs and the power of true entrustment decision if you do that. So what actually entrustment decision is not so much to allow further progress to a next stage of training, but actually to allow to contribute to patient care. That's actually what an entrustment decision is. So if you don't do that, there is a risk that entrustment decisions become like tick boxes, that people just sign off for them, but there's no difference. So learners should not so much experience the feeling like I need to get an EPA, but I need to get qualified for this EPA and permitted to do it. And every summative entrustment decision should actually be followed by increased responsibility. And these decisions should not be felt by learners as an end of a stage, of an end of a phase, but actually as a beginning of a phase, because now they're actually at a higher level of qualification to do something. And finally, trusting begins with acquaintance. That's also for curriculum developers something important to think about. If you have very short rotations, how can you actually build trust? How would people really know that this person is really ready for unsupervised practice? You need more than incidental supervisor trainee interactions. So now the next thing to think about is not all objectives of medical training can be captured in EPAs. One example, interprofessional collaboration. Some people have said interprofessional collaboration or even interprofessional education should be an EPA. Just to remind you that EPAs are activities. They're not behavior, they're not personality traits. EPAs must have identifiable beginnings and ends suitable for entrustment. That's difficult here. There must be a phase of prohibition to enact this EPA, followed by a phase of permission to act, and separated by a grounded, valid decision. So can one prohibit interprofessional collaboration before entrustment? Can there be certification or credentialing for interprofessional collaboration? Can you schedule a trainee to do this with a beginning and an end of that activity? And if EPA, interprofessional collaboration would be one EPA, is there no interprofessional collaboration in almost every other EPA? So not everything is easily to translate in EPAs. That's just a warning. Finally, technology for EPAs is useful and emerging. Programmatic assessment for EPAs, defensible as decisions for entrustment qualification requires information from multiple sources, like supervising clinicians, other coworkers, maybe even patients, as close as possible at the point of care. The regular documentation of recommendations must be made using ePortfolio if possible. Mobile applications that minimize time and feed into a portfolio are very, very useful. And there are now several excellent tools are quickly being developed. This is an example from an AMI guide that before we had ever had these was a suggestion that we made. Why don't we create these types of mobile devices that you can use like in almost a split second to provide feedback and to make a qualification that feeds into a portfolio. Now you can actually see them being made. This is one for surgery. This is one being used for undergraduate medical education. Here's one that's being used in anesthesiology in Switzerland, now quickly being expanded to many other programs too. So that was my final things to think about, and I'm happy to give the word back after this very long talk. And thank you for your attention. I'll stop sharing my screen.
Thank you so much, Dr. Tankata. This was very enlightening, and I'm sure all our audience benefited a lot from all your expertise. Thank you so much. There are quite a few questions. Personally, I found that the whole concept of assessment being retrospective to prospective was really enlightening to me. That you usually think of, okay, if you did 1, 2, 3, 4, then you're good to go. Whereas you're challenging us to think about, while that person would have done 1, 2, 3, 4, that's good, thumbs up. But prospectively thinking, are you ready to sign off that person to do A, B, C, D, right? So that was a really neat way of thinking. Well, before I go to the questions, I'd like to say that still I have on my board for the past 8 years, I have Tankata's word about the qualities one need to gain trust as ability, integrity, reliability, and humility. That's always on my board in front of my table. So that's something that always motivates me, drives me. So thank you. So quite a few questions, as you would guess. The first one is, with enhanced focus on education and assessment across the continuum, what are your recommendations to improve communications and handoffs from UME to GME so that there is trust by the program directors of what students are able to and ready to do?
Yes, so that's a very good question. It doesn't only hold for like undergraduate, postgraduate, but sometimes also for one clerkship to next clerkship. And it's always a critical question. So basically, in principle, my vision would be that as a school, you should be responsible for the totality of training. So handoffs within your organization, I would recommend that we actually do that. It's not, I know that learners are sometimes worried that they would be viewed in a biased way when they start a new phase of clinical training and people already know things about them. But they have to realize that it can work in both ways. It can also really help them if they have some deficiencies to actually to have them be attended in a different way than some other learners. So it actually, I think as a school, you're responsible for the whole set of training. So from undergraduate to postgraduate, that's another question, but it's also a very significant question, specifically because USMLE Step 1 will not allow postgraduate programs to use that as a selection instrument. They would like to see more qualitative information, which is actually not bad because the information of USMLE Step 1 was not very much correlated with clinical competence anyway. So, so the question is how much information and what type of information is important. I think there is different ways to think about that. You have to be careful, of course, and I understand the worries. There is one approach that we are actually now beginning to evaluate. As I said at one of the slides, it would be good to start with a conversation with a new trainee, looking at their background. What are their experiences when they start postgraduate training? And if you would actually map that to EPAs, and we're doing that in veterinary medicine actually now in a project of one of my PhD students. And actually here we're talking even about a job. It's not even a next stage of training, but it's actually doing after graduation, starting in an emergency veterinary department with 23 EPAs. And here's where the learner, or actually the employee, is being asked, now please check with those 23 EPAs, where do you think you need supervision? Would that be for each of these 23? Would that be direct supervision? Would you need somebody actually sitting to you? Indirect supervision? Could you do that all by yourself? Or have you so much experience that you could actually supervise other people? I think that's an approach to take into account what the background of a person is when they start a new phase. So in some way, I think we have to find ways actually to do that in education, in medical education too. And not so much like in secrecy, but I think together with the learner. And I think many people, most of actually our graduates will do pretty well in most residencies. And I've recently actually even suggested that if you really cannot choose between two residents, you might even draw a straw and say, well, we are responsible for postgraduate training. People are not identical. We need diversity. We don't think that there's only one measure that is important to make sure that you're doing well. There is diversity among people. And so what we really need to do is qualitative information and say, well, you are coming here, we'll make together with you the best of your program. Yeah, I could go on, but maybe I should not fill all the time. Yeah.
Thank you for that. And the next question is from one of our students, Jenna, and you and I have spoke about this as well when we met. How does EPA model work for learners who progress more slowly or more quickly? So it's a time variable.
Yes, the time variability that leads to a lot of discussion, and specifically, I would say even in North America, where you have, which is actually, it sounds like a law, but basically you were one of the countries that is rather an exception to use a national matching procedure, making sure that everybody starts on July 1 with postgraduate training. And you're qualified as a person in a class, and the class is already named when you start training. So if you don't meet that exact time frame, it feels odd for you, because either you are behind, or you're so within that framework. It's not so easy to make variations. I think we're now progressing to thinking of that more. It's easier in my country, actually. We can do that. And most of our learners in undergraduate training, which is 6 years, we don't have a bachelor degree when they start, is 6 years. But most students actually take, 6.5 years or 7 years. It's all individualized in the last years anyway. So it doesn't really feel odd if is there some variation. Also, our postgraduate training in the Netherlands, since a few years, using EPAs across all postgraduate programs is the paradigm. There's no fixed duration of training anymore. It's all flexible. There's a standard, that's still the same standard, but there's no, I would say, punishment or so when people are slower or quicker in any way. So that's actually adapted. So I think, but if you don't have the possibility to adapt your schedules or so, you might think of, for fast learners, to add EPAs to their program. Actually, it could be elective EPAs. You might be able to provide someone with experiences that other students don't have, because they actually have already met everything that's important for graduation. So here's where you can build in some flexibility, even though your time frame is still fixed.
Thank you. There's a question from Hadil, and I'm just requesting him to unmute and ask the question, if possible.
Hi, good afternoon.
Oh, sorry, it's a she. Okay.
Hi.
Hi, Hadil.
Hi. So my question is about a primary care exception. So we have under CMS and primary care, we only supervise the interns directly for 6 months, like as one-to-one basis. And at the end of the 6 months, they expected to transition into more of a as-needed supervision. And during the week is multiple preceptors, just because this is how primary care is. So I find it very difficult on knowing how to, when I precept after the 6 months, is what is the actual competency of this resident when I've not known them or haven't seen their actual assessment at the end of the 6 months.
So let me understand, because if you are in primary care and there's a phase of 6 months, how can you not know the learner? Or is that there must be supervisors that have the benefit, actually, in your case, of a long-term relationship with a trainee, which is different in some other specialties where there's short rotations and so. So I would actually think that you have a better picture. I was actually anticipating on a different question that you would ask, that I hear frequently in primary care or family medicine, that they would say there's only one preceptor, and how can we actually validate our summative decisions if we only have one person? And usually I would suggest there are other people around. So maybe you should give them serious roles in entrustment decision-making, specifically in summative entrustment decision-making. So if you have assistants, if you have a voice of patient sometimes also involved, so that you have multi-source information that builds the validity of important decisions to do things. So, but I may have missed the actual question that you wanted to ask.
No, I guess this is definitely true. You have multiple people of you, and it helps in getting a summative feedback at the end of the 6 months. I think is my way I struggle most of the time is the expectation that we expect the resident, the intern at the 6 months to be able then next month to do things on their own, and if they are not, how to go by that. And it's the same thing that we may be struggling even when they transition from the intern year to second year, where there are different expectations. And it's kind of the entrustment here is coming because of they're at that learning stage, and they just have to pass it and do it. Otherwise, then you're holding their progress and their training program.
Yeah, well, they would like to have their progress held, but at the same time, if you don't feel comfortable with that person, it's going to be very difficult. So the best recommendation is to build that over time. So the worst thing is actually to say on the last day of training, we don't think we can have you graduate here because you're not ready for this yet. Don't do that. Don't ever do that on the last day. You'd have to definitely, and I'm sure you're not doing that, but it's important to build that over time. So at least at the latest, I would start doing that halfway and say, if we look at you, you're not at the stage that we hoped you to be. So what can we think with you about experiences that we want to add? And then I think the conversation should be, is it your specific capability for specific EPAs, or is it the more, I would say, general components of unpredictable working, or the domain of humility, I would say, would be you're overestimating yourself, and we don't think you can do this well. You're not really open for feedback of our assistance or maybe even from patients. So that conversation is so important, because they need to understand why they are not yet trusted to do, or not yet ready for your complete confidence. So that's what I can say. At the end of the day, if it doesn't work, I mean, here's where you have to really think of how can you keep people maybe for a few months longer, because you think they are not ready to do this or that because they've never encountered that, and really want to see that they really can do that well.
Thank you so much.
Yeah, thank you, Hadil, for chiming in. There's a second question from Jenna, our student. You talked about integrity, capability, reliability, and humility and agency being the key factors for gaining trust. Her question is, how can that be used, the framework can be used in recruiting students into medical school? Or can that be a framework that can be used to select future medical students?
So I think it's important, those are features that extend over a longer period of time, and I agree with that. I do have difficulty to use that for selection criteria. And probably the primary reason is that, actually there's two reasons. One is that it is very, very difficult to have any reliable instruments to measure that well. I mean, if you don't know people, they can easily pretend things, or if they don't present them well, they might even suggest that they're not as good as they. So if you want to be sure that a person is predictable, you'll have to just see them over time. There's no other way. You can't do that on a Friday afternoon and say, or based on any written information. So it is a very difficult selection instrument to use. But what I would recommend is, as soon as you have those people, and that is the second argument too, from the very start, have conversations with them. All those elements are important. And you have to realize from the very start, we are going to watch this from you. So these are features. We're interested in your skills, and in your competence, but if you don't show humility, if you're not even ready to show, here's the limitations of what I know, and now I need help, we cannot trust you to do things, which is difficult for students, because most students have been trained to shine all the time. The better they look, the better they are. And so they have to show all that confidence, but also they're terrific. But that kind of collides with the idea of humility. So if you have to explain to that, that's a component of high quality patient care, actually, to have that conversation. So I have the conversation from the start. That's what I would recommend, because you are also their educators. You can educate them. If you can't select them, you can help them actually to grow and develop in all those areas.
That's a great response. Thank you for clarifying that. The next question is from going back to a presentation about where you mentioned not all training objectives can be translated to EPAs. Does that mean that we have to tease out all the unassessed objectives and design additional assessment tools?
Well, let me say this. Let me use the same example that I used in that slide. So interprofessional collaboration is highly important. There's no question about that. I'm not suggesting because it's difficult to translate into an EPA, that's not important. But think of it, as I said, in most of the work that you do, specifically like in hospital work that you're working with other people. It's hardly thinkable that you do things without interprofessional collaboration. So in each of these EPAs, interprofessional collaboration will be important. So that is a component of your evaluation of the learner. It's not just their skills. So you have to factor that in the entrustment decision. So in the entrustment decision, and for some things it may be more important than for other things, but if you just think of surgery. So if a surgeon cannot work interprofessionally well in the operation room, there is trouble. I mean, there is danger for patients. Their patient safety might be harmed if they can't do that well. And one of the reasons why things go wrong in hospitals and operation rooms is interprofessional collaboration. So if you would, in surgery, define those EPAs, you say, we're only trusting you to do an appendectomy. If you could also collaborate interprofessionally, it's a component of our evaluation of that EPA. So many things that in themselves would not be a specific EPA, and you're qualified for that EPA because you're hired to do interprofessional collaboration. That sounds like odd. You're doing that on Monday morning, and you're doing that well. That Tuesday, it's not so important for interprofessional. That's not what you're doing, right? So it is actually a component of separate EPAs. And so there are more things that in the realm of professionalism that are that is important. If you go even further, some people might argue a good physician is someone who knows something about politics, statistics, or even humanities. If you never read a novel, you're probably not a good physician. Well, all those things may be valued by a physician, in your physicians, but they're not really translatable to an EPA that, in the sense that we use them in education.
Thank you. Others, please type in the questions if you may have, or you can raise your hand and ask questions while you're thinking. My question is, what is the student's role, Dr. Tankata, on seeking evaluations in a workplace assessment setting?
So my vision is that the students have a very active role in it. So it is, so I would say a clinical curriculum is a curriculum that is not only owned by the institution or by teachers or a team, but it's also owned by the students. So if students know, I mean, we know, at least from our experiences with using EPAs, that students value that they have more sense of where they're heading using the EPAs. But they should also be wanting to progress by asking people to be observed for EPAs and actively think, am I ready for the indirect supervision? And they should be asking that, actually. So I think that even though you're responsible as an institution, the student and in individualized EPA-based curricula should also be very actively busy with looking at experience. So if, give an example, if there's something that you say, well, here, we're not really sure if we can have you do this EPA by yourself. You just have too little experience in doing that. Here's where the student also can actively seek things, or being asked to be scheduled of moments that they can actually have that experience, or there might be different ways that actually they can have an active role in looking at the affordances that are given in the clinical space to create that experience for themselves. I think they should have a very active role.
I agree totally. Thank you. And nowadays, technology has made it easier. Like you pointed out, the apps that students carry on their on their mobile devices makes it only easier and justified that they seek out those assessments, because it should be in their interest as well to grow. Thank you.
Yeah, I can tell you there's one example of an app that actually has two versions, a student version and a preceptor version. So how that works actually is that the student uses the app, has a QR code of themselves. Any attending can use their smartphone to read that QR code, and then suddenly are also the evaluator. And then they can actually both evaluate them. So the student can evaluate themselves, and the preceptor can also evaluate. They can compare their conclusions about an EPA that has just been done. So that's very helpful, and that stirs the discussion between the two, and it gives depth to the feedback that the student can receive.
Yeah, I totally agree.
Yeah, it's fascinating technology. It's going to help us.
Yes. And the next question is, do you feel evaluators can be candid about a learner's assessment if they feel that there are high stakes attached to their assessments?
Well, in the picture that I showed, the first step is, of course, to think of it as high stakes, to think of it, this is a serious recommendation that I'm going to give. This person is ready for indirect supervision. I find it difficult to not be candid. I think it's difficult. It's not, yeah. So I would never recommend not to be candid. I do understand that it's not an easy task actually to talk with students about things that they are deficient in. But I think one of the core qualities of educators is to have the courage to do that. I mean, that's a skill of an educator. If you can do that, you need faculty development. You need tools in communication skills actually to be candid for learners. If you don't do that, and I think it happens too often that people do not say that to learners until it's almost too late. People actually proceed in their education until somebody actually finds out, how does this person ever get to go at this stage of training? How come nobody ever warned this student? Or so it is not easy, and so of course the easy way out is just not talk about this, but I think it is a responsibility, just like being willing to sign for saying you're ready to be entrusted with this activity. So it is, I think, if people find that difficult, we need to have faculty development to train educators to be able to do that, to learn, to have them learn the right language to go about with students to do this. And then finally, students also, it's also expectation management. We have to say to students, nobody's perfect from the very beginning. Even though you think you've had straight A's for all your life, you are a learner, and a learner doesn't know everything that needs to be known at the end. So at a certain point, we're going to say that to you. that's part of education. Part of if you're always perfect, why would you need education? Yeah,
That's very true. All right. We have two hands raised, Song and then Joel.
Yes, okay. This is Xiaomei, and yes, thanks for insightful presentation, and I think much progress with EPA now. And so I want to ask the current situation. We use CBSE to guide curriculum, which then make connection with assessment. So basically, we look at curriculum mapping, then assessment mapping. So I want to ask, how do you think EPA will impact the curriculum design? And do you feel this could be a challenge if we adopt the EPA because they're not easily mapped into competency-based education and objective?
so if you say curriculum mapping and assessment mapping and EPA for a whole curriculum, is that just for clinical education or for the whole curriculum? So are you including basic science? Is that your question too? How to actually involve them and courses and all elements of the whole course? Or are you talking about clinical education only?
I'm talking about all of them. Yeah, we use competency for all of those courses and collections. Yeah.
Yeah. So the question that frequently arises actually, so how, what is the role of basic sciences actually for EPAs? So if you have an EPA and have described it well, there is a section that actually says you have to realize that if for this EPA, student really needs to master this knowledge, and they have to have skills that must be trained in a simulation situation. We won't even start thinking of entrustment if you have not passed the skills test, or if you don't know this. So here's where we actually should go back to basic scientists with EPAs. It's backward program of your curriculum and say, now think of in the basic sciences or a chemistry teacher, what would be your contribution to the knowledge that students really need before we can trust them to do this clinical work? And it may be details that are not really relevant for the moment at the point of care, but if you don't have that background knowledge, you may not provide that care so well. So here's where you start a dialogue. Of course, EPAs are not, don't make entrustment decisions before people are in a clinical space. As again, entrustment decisions are really decisions to trust people with contributions to healthcare. So that's not something, it's not like passing a test in basic science or even in skills test. There's one exception that I might highlight, and that is in the basic life support, that people would say, well, we're not, you should be able to do that even though you have only had a skills course, because we can never observe you do that in practice to qualify you, because every time we have an emergency, we'll have a better doctor than you to take care of the patient. So that would be, but usually almost everything in EPAs is we have to observe people do things before we can qualify them to do that without supervision. But yes, I would recommend you just sit on the around the table, including basic science people, look at your whole curriculum and think of, here's an EPA. So what components of those EPAs can we actually find in different courses to prepare students optimally for doing that work in the clinical workspace?
Yeah. Thank you. Joel, please go ahead.
Yeah, hi. Terrific presentation, of course. Is it fair to ask if there is a predictive validity between EPA assessments in the trenches, in the workplace, skills assessment, and other examinations such as step 3 or certification examinations, or even validity that's predictive between EPA outcomes and program directors' assessments of trainees as they transition from UME to BME? Is that a fair question to even ask?
Yeah, of course. It's always a fair question to ask that, and it's a fair question to ask: are we training better doctors? That's a difficult question, but the connection, the predictability using step 3, I haven't seen studies doing that. Of course, as you will appreciate, I'm not in a position to do studies like that in the Netherlands. We don't have that, but I think it would not surprise me that pretty soon we'll find those studies that connect USMLE step 3 to working with EPAs. I would have to look to proxies in the literature. What we do feel is that in many programs start using EPAs, so there's a lot of like descriptive information that shows that people actually progress in a predictable manner in levels of supervision. Eric Worm in Cincinnati, for instance, has produced a lot of data to show that. The pediatric programs in the United States also have been collecting that information. There's still lots of things to do, and it won't always turn out the way you hope, but that's research. We have to do it. And most people actually start doing this simply because it makes sense. Because EPAs are things that they find that's what their daily work is about. And they say, well, why don't we frame it that way?
Thank you. I know it's already close to 10 o'clock for you, Dr. Tankata. Thank you so much for taking the time and spending that with us and illuminating us with your work on EPAs. And as you know, there's every reason for you to take pride in your work because it has changed the landscape of how medical education is transitioning towards not just medical education. As you pointed out, it's health professional education and veterinary education and every other education that touches human and livelihood is impacted by your work. So thank you for your work and thank you for spending your time today with us. With that, I'll transition to, I'll hand it over to Jason.
It was my pleasure. Thank you. Yeah.
Thank you, Dr. Rajashekharan, and thank you, Dr. Tankata. And we are about to begin our second plenary. And with that, I would like to turn it over to my esteemed colleague, Dr. Diane Levine.
All right, it's my great pleasure to introduce Dr. Luis Pangaro, MD, MACP, who will be our next speaker. Dr. Pangaro is professor of medicine at the Edward Hebert School of Medicine of the Uniformed Services University of the Health Sciences. He earned his medical degree at Georgetown University, where he also did his residency in internal medicine, followed by a fellowship in endocrinology. He was a research fellow in endocrinology at Walter Reed Army Medical Center and developed a radioimmunoassay for 3,5-diodothyronine. Dr. Pangaro joined the Uniformed Services University with positions as director of fourth-year programs, clerkship director, and vice chair for education. He was appointed professor with tenure and served as chairman of medicine and then interim dean for the school most recently from August 2020 to May of 2021. Dr. Pangaro's scholarly work focuses on clinicians who evaluate the competence of trainees. He has published numerous articles, chapters, books, and his presentations related to medical education are so much fun and educational to watch. Using the model of a radioimmunoassay, he created standardized examinees to calibrate the validity of the prototype of clinical skills examination that was used by USMLE. He introduced the concept of synthetic development frameworks for defining expectations of students and residents that is now used as part of the ACGE milestones. And his RHYME model, reporter, interpreter, manager, educator, is an alternative to the traditional knowledge, skills, and attitudes paradigm and helps assessors capture the movement from understanding into action and provides a diagnostic approach to assessment. This model has transformed the way we think about and assess student performance. From 2009 to 2014, Dr. Pangaro was the faculty leader of the curriculum redesign for the School of Medicine at Uniformed Services. And as he assumed positions as chair and dean, he focused on developing faculty educators and leaders. He was a facilitator of the Stanford Faculty Development Program and has worked with more than 1,000 military faculty on their teaching skills. Starting in 2000, he created a 6-day course for military GME program directors in assessing competence, and nearly 500 program directors have participated in the last decade. He has published widely and spoken widely on faculty development and leadership in medical education, and he co-directs the annual Harvard-Macy International Program for a Systems Approach to Assessment in Health Sciences Education, which is where Dr. Buza met him. As chair of his department, he initiated a Master's of Health Professional Education and a PhD program in medical education, in which he taught courses in leadership in medical education and in methods of clinical teaching. I had the pleasure of speaking with him last week. He shared that he continues to work with students in the clinic, providing feedback on their performance. He has personally evaluated and given individual feedback to several thousand medical students, and nearly all of them are still part of the military medical community. Dr. Pangaro is Sasquatch, or Bigfoot of medical education. In other words, he left and leaves a very large footprint, which is hard to follow. He has served as the at-large member of the National Board of Medical Education and on the editorial boards of Academic Medicine and Teaching and Learning in Medicine, and is a past chair of the Research and Medical Education Conference Committee of GEA and the AAMC. He served as the president of the Clerkship Directors of Internal Medicine and of the Alliance for Clinical Education that coordinates 8 national organizations of clinical clerkship directors. He has been honored by the AAMC with the Glazier Distinguished Teacher Award, by Uniformed Services by the Clements Award for Excellence in Education, the inaugural Carol Johns Teaching Medal. He's been recognized by the MBME for the Edith Levitt Distinguished Service Award, and by our organization, Clerkship Directors in Internal Medicine, with all 3 of their awards, many of which are now named for him. He was recognized by the Army chapter of the American College of Physicians with its inaugural medical Master Teacher Award, which is now named, of course, the Louis Pangaro Master Teacher Award. And from the Washington, D.C. chapter of the college, he received the Saul Katz Teaching Award and its Laureate Award. Dr. Pangaro was named the Distinguished Medical Educator of the Association of Program Directors, and in 2018, the John P. Hubbard Award from the NBME for excellence in the field of education. Lest you think that Dr. Pangaro is unidimensional, focusing only on medical education, he has other talents and was recognized by the British Embassy Players for his production of Shakespeare's Hamlet. So from Hamlet, my words fly up, my thoughts remain below. Words without thoughts never to heaven go. So let us hear Dr. Pangaro's works and thoughts about medical education.
Thank you, Ty. That speech, of course, that quote comes from Claudius, the villain of the piece. But let's see here. So tell me if my slides are available. Can they be seen? Can I be seen and heard?
Yes.
Yes.
Well, thanks very much, everyone. I appreciate the chance to speak, and it's an honor to be on the same program with Dr. Tankata, who has really had an impact on everything we do. 2 important things. One is that you heard that I'm a clinician, and my work is for clinicians, for clerkship directors and people who work with medical students and program directors who work with residents. That's number 1. And secondly, the issue of accountability is very important in my system, since I'm retired from the United States Army, and most of my surgeries, since I beyond the age of 50, have been by former students. So the issue of whether we trust them, Ola, is absolutely critical to almost everything that I do. It's an absolutely critical thing. Notwithstanding, we still made mistakes. Every one of our medical students trains in the military GME system, and then they owe another 7 years beyond that. So this gives us a laboratory for longitudinal research that many people don't have. We're still learning how to do this. We have an educational research unit under Steve Durning, who's the head of our master's and PhD programs, but I think we're all novices in this area. Well, I appreciate the opportunity to speak to you about my thoughts. My talk is from understanding to action and assessment systems. And what's next? What's next? Once we go beyond frameworks, the language, the terminology, whether the frameworks and the language is milestones, competencies, EPAs, even my own rhyme system, how do we build a system that supports conversation and progress for individual students? The overall theme is understanding into action, and there's a lot of ways we'll rephrase that during this talk. Excuse me just a second, I need to set my timer so I don't go too far over. Sometimes we use the phrase observation, reflection, action. You see something, you think about it, you do something. This is the fundamental rhythm that underlies most of what I'm going to say. You may have heard this phrase before, DIKW, data, information, knowledge, wisdom, sometimes called Haeckel's hierarchy, from an article in Harvard Business Review about 20 years ago. And this movement from seeing something and deciding what it means and then taking some action is the heart of my talk, and it's the basic rhythm. And when in this DIKW, wisdom, this is the attribute of the person who has moved from data to knowledge into wisdom, I think of wisdom as readiness for action. So I'm going to use wisdom whenever it appears as a synonymous to be ready to make a decision or to act. Just so I'm clear with this somewhat abstract terminology, I'm going to begin with a concrete illustration from medical education about the movement from understanding into action. So there's that pyramid again. Forgive the idea that it is a pyramid. And on the right, and lower right, you'll see next to the word data, we make an observation that we have an individual who can do an accurate history and physical. Let's consider doing an accurate history and physical to be an entrustable activity. And on this particular patient in front of us, their history and physical is accurate. So let's say that person is a reporter. When you ask them to come up with a differential diagnosis, they're really not able to do that. So they're at the reporter level, but not interpreter. That's the observation, that's the data. Now, how do we convert it to information? We place it in context. And we say that if this was a pre-clerkship student in the first year of med school, that would probably be okay, thumbs up. But if it were a second-year resident in medicine, family medicine, or surgery, that would be thumbs down. So an observation becomes information when it is placed in a framework or a context. Well, now we have an observation about this learner dealing with this patient, and we say they're just a reporter. What do we really know? Do we have sufficient observations? And the answer is we need a lot of patients. We need broad sampling across EPAs or whatever activities you want to call them in order to decide that we actually know something about the learner. What Ola called before competence, an attribution of the individual as opposed to the task. But let's say over the course of the last 2 months working with this person, we've observed many cases, and on average, they are a reporter moving to an interpreter. And if we feel we have confidence in the number of our observations in our blueprint, then we think we know something. We can classify this person as a reporter and interpreter. Now we have to have judgment, wisdom. What are our values? And how does this pertain to our actions? Well, there are two different kinds of actions to take. One is an educational action, which we call feedback. And the other, at the end of a rotation, something we call summative, is an administrative action. Does the person get credit? Do they advance from first year to second year of the residency, from third year or fourth year of the medical school? And in a 4-year American program, do they advance to PGY 1? In my lexicon, feedback is an educational action and grading is an administrative action. But either way, we have to make some kind of a judgment. So this is information processing in this movement from understanding to action. And I tried to use a concrete example applying to education. Let me rephrase this in another way. So we begin at the bottom, we have data, we have observations of tasks. which can be made in EPAs or rhyme. Then we classify the individual as a reporter moving to interpreter. Then we have sampling. And then we're going to make some inference about readiness. And again, this is Ola's distinction between activities looked at in EPAs and competencies, an attribute of the individual. And based on our inferences from all our sampling, we're going to make a decision. The decision is whether the resident finishes and goes into independent practice. So this is what I meant by the movement of understanding into action at the level of the assessment system. Now I'm going to use understanding into action at 3 different levels now. First, of caring for the patient. Excuse me. Secondly, of the progress of the learner towards independence in the curriculum, that's here in the middle. And finally, the process of assessing learners within the educational system. And in each of these, I'm going to try to show you that this rhythm or this sequence, whatever you want to call it, the movement from understanding into action, is in each of these. And therefore, all my faculty, whether they're PhD scientists or whether they're clinicians, will recognize this basic underlying rhythm. My theme is the unity of these processes at whatever level of granularity you want. That there is simplicity in this rhythm of observation, reflection, action. There is familiarity, which allows us to build on what the faculty already know. They already know how to do. They know how to go from observations, history, and physical to diagnosis and to a patient's plan. This validates their own experience. It gives them a sense of enjoyment of their craft, of confidence, and most importantly, it avoids burdening my faculty. As the chair of medicine with 1,200 faculty between Bethesda and Honolulu, I know how beleaguered and burned out so many of the medical faculty are these days by the many processes involved in the business of medicine. And this is even before COVID. So a lot of my thinking is what happens to the faculty and what they can do. Oh, yes, I have no financial relationships. And most importantly, you've heard me say it, I do not represent the opinions of the Uniformed Services University or the Department of Defense. Now, I think we would all agree that our underlying principles are fairness, justice, whatever you'd like to call it. We have to be fair to society, that each resident we graduate is ready to do the job, or each medical student is ready to be a PGY1, and they're somehow competent to do what we expect of them to do. And this is the idea of competency-based medical education that Dr. Tankata mentioned. It's an accountability to society. The second group to whom we have to be fair after patients are students. The evaluation system and the evaluation framework should be transparent. There should be feedback. And for me, most importantly, there should be trust of the faculty. I am as interested in whether the students trust the faculty as whether the faculty trust the students, because leadership is what is critical in leadership is that the person who is in the weaker position trusts those above them. And I would have to say that if it was a crapshoot who you got for an attending, you got one faculty member who was a hawk and the other was a dove, and it was a crapshoot who you got, there was not consistency, then the whole notion of professionalism is crap. There's no such thing as professionalism in the medical education culture if the faculty cannot be trusted. Finally, and this I think is neglected, we have to be fair to teachers. Not only are teachers provided faculty development, as Ola and others have said, in order to do the job they have, it has to be feasible for them. We can't keep adding more burdens onto the faculty. They have to be protected against people like me, the educator class, who has a great desire to see my ideas imposed on them. And I have to protect them, of course, from students who might complain that they are being harassed when in fact they're being given helpful feedback. So the principle of fairness runs through everything we're going to talk about. So we'll talk about the problem and the barriers in clinical education and what the educational system provides in terms of concepts, terminology, calibration of teachers, and how we convert information into decisions. Let me specify the context. Let me make a distinction between descriptive evaluations using clinical grades from teachers and quantified evaluations such as multiple choice and simulations. I sometimes call these in vivo with real patients and in vitro with simulations. And my focus today is the grading in the clinical setting. Now, teachers' evaluations have had a bad name for decades, ever since I was a medical student years ago. And 30 years ago, Anya Tenesk from GW wrote a paper saying that the evaluation of students lacked meaningful comments, there was insufficient definition of criteria, inter-observer variability, late submission of evaluations, delay in feedback to students, and similar complaints have been made since. Reed Williams, Deb Clayman, Bill McGahey wrote a paper about 15 years later about the accuracy of evaluations, agreement within and across teachers, inferences about competence, and the whole utility of the whole process. So there's always been a problem. And what are the barriers? Well, I've inferred these lists from the Williams paper. There are cognitive, emotional, and logistic barriers. The cognitive barriers that are that goals and objectives may vary within a medical school, from medicine to surgery to peds to obstetrics, and even across teachers. Sometimes these goals and objectives and expectations are very elaborate. I'll give examples of that. And there is still a need for construct alignment with what's already in the head of the teacher. The emotional barriers is you can't assume that the teacher is a dispassionate servo mechanism working for the educational leadership, the deans or the chairs or the clerkship directors. And the whole idea of giving a grade can sometimes be very emotionally fraught for teachers when they're working with students whom they have been mentoring. And finally, there are logistic barriers, needing time to observe students, time for faculty development, time to complete all these evaluation forms. And whether the forms are on paper or they're in my cell phone, I'm being harassed constantly with people asking me to complete their forms. It's like patient care RVUs on steroids. So let's deal with the cognitive issues first. So much of what we've dealt with over the last 3 decades come from Bloom's taxonomies, something in the head, something in the hand, something in the heart. And this has yielded these kinds of lists that were made by people like me in the 90s and were championed by the AAMC and the Medical Schools Objectives Project. So we have knowledge goals, skills goals, attitudinal goals. And of course, the question is, who can deal with all this stuff? You know, who's got the time to memorize this? My faculty don't. I don't think any dean knows what that list is. So as opposed to this elaborate stuff, what is the role of economy of action and simplicity in what we're doing? And when we talk about observing, whether they're competency, EPAs, milestones, rhyme, whatever it is, how many observations do we need to make to assure the public? And do we have to document absolutely everything, or is there still a role for inference? As Dr. Tankata said, you cannot predict everything the student or the resident will see. So there has to be some inference. And yet, regulation and measurement has become a growth industry in medical education, just as it has in the business of medical care. And I worry about the burdens on faculty, not just the dollar cost, but the emotional costs. We're members of CDIM, as Dr. Veen said, the clerkship directors in internal medicine. Here's their top 5 clerkship expectations: to generate a differential, conduct a complete and accurate history and physical, obtain focus histories, provide an accurate oral presentation, interpret the results of basic diagnostic tests. Well, this list is fairly familiar. Something like it has been used since I was a medical student in the 1970s. Here's a clerkship evaluation form from 1985. This is more than 35 years ago. And in the middle here, you see these areas of performance. I'm going to explode this for you. The quality of histories and physicals, ability to analyze data, use of texts, oral case presentations, procedures. These lists have been around forever. They're often made into a typical clerkship evaluation form. This is the front of a 2-sided form with lots of behavioral anchors. And of course, we know that teachers often just whip the form. They're very impatient with our long lists, even including all these behavioral anchors in them. Well, why is that? Well, one, they don't have time, but they also realize that whipping the form is probably just. And we seem to have this mistaken belief that the evaluation form or a piece of paper or something on your cell phone with a list of EPAs, competencies, rhymes, or milestones is somehow an evaluation tool. It's not, of course. The form simply communicates goals. The teacher is the tool. So the critical focus should not be on the form, but on the teacher. And these forms are often whipped, and there's probably justification for that. Here, you don't need to look at the list. Here's a typical list for intern evaluations with 15 or so items. And the factor analysis will show you when we look at the list here, histories, physicals, technical skills, written and oral communication, that all of these collapse into two concepts, professionalism, expertise. And there are a dozen studies that show that no matter, when you have a list of 10 to 15 items, it always collapses to duty and expertise, except if you're in an emergency room, then it collapses to manual skills and cognitive skills. So the whole idea of these forms and the elaborate list is a little crazy. So here's the AAMC core EPA list for entering residency. I don't think I need to read it to all of you. You're probably very familiar with it. And all I'm here to say is that this list has been around. There are 13 of them, but 9 of the 13 were in existence when I was a medical student, and 11 of the 13 since I was a clerkship director in the 80s. And having a list just hasn't worked. So as you may know, we've proposed that the EPAs here listed number 1, 5, 6, and 9 would fit under the reporter rubric. 2, 10, and 3 would fit under the interpreter rubric. And thus what I'm doing here is I'm using the EPAs from the AAMC to populate the rhyme framework. And here's a critical slide. On the left, you see reporter, interpreter, manager, educator. And on the right, the dimensions of performance. So reporter is gather a history and physical, document a clinical encounter, provide an oral presentation, collaborate as a member of team. And these concepts of frame of reference and performance dimensions are going to be important when we talk about how the system helps the teacher and the learner understand what the evaluation rubric is going to be. Just as an example, here's the internal medicine patient care milestone. You don't need to read the form, but it collapses to observer, reporter, interpreter, early manager, and manager educator. And I can show you this thing with, as my colleague Paul Hemmer calls these rhymestones, for anesthesia, for surgery, for pediatric psychiatry. And the reason it does it is not because rhyme, I'm smart in creating this framework rhyme, is because that rhythm, observation, reflection, action, report, interpret, manage, it underlies everything we do. And so the way we think of it is that there are different degrees of granularity. I'm sorry, it's on my screen here. So here's rhyme, and then there are 6 competencies or 7 KenMed roles. There are 13 EPAs, 23 subcompetencies and milestones, and it's a question of the granularity. I want to emphasize, you need both. It is not sufficient to have the framework, rhyme, or whatever you want to call it, OSA. You must have the dimensions of performance within it. And I think a lot of the work we need to do is to basically show how the big framework, the big picture, the rhyme picture, or something like it relates to the granularities. So what is the role of frameworks? Ola and I wrote a paper a few years ago on frameworks. A framework is a real or conceptual structure intended to serve as a support or a guide for building something. It's a shared mental model. Now, there's going to be 3 levels in the system I'm talking about building. And we're going to begin with observation, in which we structure teachers' observations down here at the lowest part. And then later on, we'll talk about calibrating the teachers and combining the information. And at the lower level, structuring teachers' observation, we're talking about the framework that is being used. And I'm going to begin with talking about understanding into action as the framework. So the process of caring for the patient, the progress of a learner towards independence in the curriculum, and the process of assessing learners can all be seen as information processing, movement from understanding into decision-making. And first, just to be elementary, the process of caring for the patient. Understanding, doing a history, physical, laboratory tests, making a problem statement and diagnosis, and then actions, a diagnostic plan, a therapeutic plan, shared decision-making with the patient, consultation, further reading. So this is the movement from cognitive or a diagnostic process into ethical shared decision-making. If you will, it's a movement from knowledge into wisdom. So this basic rhythm of understanding into action is understood by all my clinician teachers anywhere in the United States or Hawaii, or as far as Hawaii. They've been doing this for 7 years. They don't need me to beat this into them. The rhythm is familiar. History and physical assessment and plan, SOAP, which in my lexicon is story, observation, assessment, and plan, and then into rhyme. The rhythm is always the same. Just quickly, a word about the rhyme scheme. I'm not sure how familiar everyone is. It captures this movement of observation, reflection, action, which is described by Francis Bacon 400 years ago or Aristotle 2,500 years ago. There's no magic in this. Everybody agrees this is the structure of human activity. So that what I just covered was caring for the patient. Now let's talk about progress in the curriculum of the learner towards independence. And what do we mean by a reporter? A reporter is somebody who gets the facts. A reporter takes ownership of working in patient care and monitoring their own patients. As my colleague Paul Hemmer says, a reporter can answer the what questions. What are the symptoms? What are the physical findings? What's the story? What's the labs? What are the medications? A reporter accurately, reliably gathers and communicates information on their own. And this takes knowledge, trust, responsibility. And what I'm trying to show in these green highlights is that this is not simply a cognitive function or simply a physical exam. You have to be able to examine the patient. To be on the surgery service by 6 o'clock in the morning takes something in the gut or in the heart. Responsibility, hard work, and trust. And this is what we meant by a synthetic framework in which knowledge, skills, and attitude are combined. And here's the short summary. A reporter takes reliable ownership of the findings, an interpreter reliable ownership of explaining why the patient has the findings. A manager takes ownership of planning with patients on how we're going to figure it out and how we're going to take care of it. And the educator takes ownership of improving care through study. So that's the summary of the rhyme. In rhyme, this has been our framework since the early 90s. A finishing MS2 in the pre-clerkship period should have the basic reporter skills and have the science to interpret. A clerkship student should be a reliable reporter moving to interpreter. A finishing resident should be reliable at the manager-educator level for all the things in the core of their own specialty, whether it's medicine, surgery, or peds. And they should be able to do this whether it's inpatient, outpatient, or in consultation. And in my lexicon, the word competent has a very generic definition. It means you're able to give to a situation all that the situation requires. That's what competence is. You can give to the situation what it needs, whether it's KSA and some combination, and not a lot in excess. And over the course of from the second year of medical school through the end of the residency, PGY3, people get better in their rhyme progress, illustrated here on the left. And not only do they get better, they actually get more and more consistent. So by the end of the PGY year, an internist should be at the ME level, the manager educator level, and everything in the core: heart failure, pneumonia, pulmonary embolism. If it was something like pheochromocytoma, which is an unusual for an internist, you wouldn't expect them to be at the ME level. But if they were just at the reporter interpreter level for congestive heart failure, which is in the core for an internist, then that's kind of a red flag. And this is one way that we help our residency directors to help their teachers understand when a resident might be in trouble. And now we have to talk about what is it that's going to, when we're going to make this judgment, this inference about are they ready for independent. There's two approaches to this, and the competency approach has a threshold been crossed. And that really depends on sufficient sampling, which is very, very hard to achieve in all the blueprints: inpatient, outpatient, consultation, emergency medicine, disaster medicine, for all the different problems one may see. Or do we use the upward slope of the curve? So what I'm after here is that this unity of action, the rhythm of rhyme, patient care, underlies everything that my faculty do. And so it is a familiar construct which has construct alignment between what's in the head of my teachers and what I'm going to give them in my evaluation form. First, the rhythm is the same: observation, reflection, action, report, interpret, manage. Secondly, they are used to making a classification, a diagnosis. This is heart failure. This is pneumonia. This is pulmonary embolism. This is a reporter. This is an interpreter. This is a manager. So I can take advantage of this previously built-in ability to diagnose or classify in my teachers. Finally, and this is the great thing that Ola has added, physicians understand this idea of I trust them or I don't. This to me gives built-in construct alignment along with the cognitive aspects, this entrustability, which is somewhere between cognition, skill, and emotion, that I trust this person. So we need construct alignment. And I believe that the rhythm, the rhyme rhythm, is critical in this. My clinicians have the ability to make a diagnosis, as I just said: heart failure, pneumonia, a pulmonary embolism. And finally, that I'm not asking the teachers to give a grade. Teachers do not like to give grades. Teachers do not give patients cancer. They make a diagnosis of cancer. So using the rhyme system, we say we want you to make a diagnosis. This learner is consistently a reporter or interpreter or manager. We're not asking them to, quote, give a grade. So again, we're trying to deal with some of these cognitive and emotional barriers. When Mike Battistone at Utah, this is 20 years ago, implemented the rhyme scheme, this is the grading distribution in their clerkship, which was an honors, high pass, pass, low pass, fail system. And then when they introduced rhyme, you can see here in the green bars, it became much more reasonable, with most students, clerkship students, being at the reporter interpreter level. And they even had some just observers, people who would have been a low pass or a fail at the bottom end. Again, indication that teachers are more comfortable classifying student function than they are in ranking them. I mentioned before the difference between the frame of reference, rhyme, and performance dimensions. And now we need to talk a little bit about the second level of our framework and how we train people to use our frame of reference training. The terminology is explained, whether it's ACGME, KenMeds, rhyme, EPAs, and we have to explain the dimensions of performance within the framework, in which raters learn and are given descriptions of each dimension and what that would look like. This, to me, is the second level of the three-level system here in bright yellow in the middle with the arrow, frame of reference training, in which we're going to calibrate the teachers, getting faculty on the same page. There's a method I'm just going to show you. It's very simple, based on face-to-face conversation, called formal evaluation sessions, in which these are scheduled sessions for students every face-to-face between the clerkship director and the teachers. And the question is, how's the student or the resident progressing? They make their open-ended comments, like open-ended interview of a patient. Then you say, talk to me in rhyme. Now, this has the advantage of we can actually ask the teachers, what do you think is the next step for these students? It's like Vygotsky's zone of proximal development. What is the next step? And for us, curriculum is an invitation. So curriculum for a clerkship student is an invitation to go from reporter to interpreter. As importantly, you're in a face-to-face conversation. You hear unexpected comments or concerns. The intern or the resident brings up something that didn't fit in your framework, and the clerkship director has the opportunity to try to make some sense of that, to try to find meaning in that with the teachers and figure out what to say to the students. Now, this basically is a schematic. Here's a student up here in the upper left in S who has 3 teachers, and then these teachers meet and talk with the clerkship director. This takes about 10 minutes. Then there's another student with 3 different teachers, and that takes another 10 to 15 minutes, and so forth. So we spend about 15 minutes per learner every 3 weeks for medical students, every 4 weeks for interns or residents. And the next day, the clerkship director will meet with the student to make sure they've already been given this feedback from their teachers. But as importantly, the clerkship director will emphasize what feedback is most important. And we think it's important that feedback is given above the level of the individual teacher by someone who knows what the med school's priorities are. Now, this process, as you can see, deals with the complaints from Xenia Tenesque on late submission and delay in feedback. And it is also a way of calibrating the teacher, so it deals with the accuracy and agreement issues. So formal evaluation sessions are dynamic frame of reference training to learn about and evaluate the student, to generate and provide feedback for the students, and develop the interns, residents, and faculties as teacher. And overall, it fosters a culture of feedback, supportive. As I think you would know, we've published the obvious. People will tell you what they won't write down. So if you're talking about identifying knowledge problems like failing the NBME subject exam, face-to-face conversations doubles the chance that the checklist or the written comments will. It also is twice as sensitive in detecting professionalism issues that will come up. This seems almost obvious. We did these studies to justify the time. Okay, getting close here. Now, is face-to-face conversations good enough to deal with the fact that we have lists? These lists of clinical skills, whether they're RIME or EPAs or any other way, these have been around for years. And our surgeons have used entrustment-like scales for decades, but still everybody graduates an occasional learner who's not ready. So the question for me is the face-to-face conversation good enough? I don't know the answer to that. I know that it's twice as good as having them fill out a form on a cell phone or a piece of paper, but I don't know that it's good enough. That's a research question we'd have to come back to. So what's the reliability in RIME? If we use the traditional low pass, pass, high pass, and honor system, and we convert RIME into a numerical scheme, A, B, C, D, 5, 4, 3, 2, 1, and we use these numbers over here on the right to calculate an interclass correlation. In the medicine clerkship, as we use it, the reliability of RIME is 0.83. As you know, that's better than a multiple choice test, better than a shelf exam. However, I'll have to say immediately that the distance from reporter to interpreter is probably greater than the distance from interpreter to manager, and so there's a dicey assumption in this study. Finally, we're going to talk about combining information into competency decisions at the departmental or school level through education or competency committees. I don't have a lot of time to discuss this. We've been doing this since the mid-1980s, and it's one of the series of conversations that we have. This conversation, let's describe the sequence of conversations. At the lower level, the teacher talks to the learner and provides feedback using RIME. At the level of the evaluation session, the teachers talk to the clerkship director or program director who provides feedback on their use of the RIME system. At the level of the competency committee, the clerkship directors discuss with each other how things are doing and is the process working. So what should the system achieve? I've got this 3-level system in terms of formative or summative. Well, formative evaluation should be based on direct observations of teachers. It should accurately reflect institutional or department goals. It should reliably occur at key points. It should develop a plan for improvement, and it should anticipate the same framework as the final evaluation. And I've highlighted in yellow some things that I think are very important, which answer the complaints in the prior studies that I mentioned about the problem with why teachers' evals have a bad name. So this is credible formative. Anticipating the same framework as final evaluation is absolutely critical, and credible summative evaluation should accurately reflect institutional goals, not the goals of the individual teachers. It should be based on multiple observers, should be consistent across sites and teachers. It should document mastery. Again, this is one of the goals of the EPA movement. And it should also document, I believe, the student's response to feedback. In the home stretch here, and I apologize for speaking so quickly, this is one example of predictive validity in our system using the internship rating form, which we send out to all of our graduates program program directors, and just look here at low ratings. The medicine clerkship system that I've just described to you with its 3 levels identified 75% of the students who were going to have low ratings. All the other USIS 7 clerkship combines only identified 8. So what I'm arguing here is the sensitivity of actually predicting what something bad was going to happen in internships. That was the first of 2 or 3 studies we published on this. Finally, I want to deal with the question of the large system. Most of us have students who are in rotations at hospitals across town. I have them not just in Bethesda, Maryland, but in Virginia, San Antonio, Texas, San Diego, Honolulu, Hawaii, Washington State. And the LCME site directors say, you have students where? They're very far away. So we've become obsessed with this issue of inter-site consistency. And this study was published almost 20 years ago by Steve Durning from our group. 7 internal medicine clerkship sites, 22 different on-site clerkship directors, 1,600 students, 10-year periods, using analysis of variance, no variance in the grading, the clinical grading in the RHIME scheme. Honors, high pass, pass, fail, which is what it was at the time, was attributable to the site. And most of the variance was explained by pre-clerkship grade point average and NBME subject exams. In other words, it wasn't a popularity contest. To go from a reporter to interpreter to manager, you needed something, and the teachers were able to do that. So there's our 3 systems: caring for the patient, looking at the progress of the learner towards independence in the process of assessing the learners in the system. And that rhythm gives us these 3 different feedback loops that I described before. We have a short loop feedback between the teacher and the learner, intermediary loop feedback between the clerkship directors and the teachers, and then we have a conversation between the hypothalamus and the pituitary up here, between the teachers themselves. Conversation, simple words between human beings. Low tech is good tech. So what are the research questions for your group, since it's a research conference? What is the relative importance of the framework, whether it's RHIME, EPAs, or milestones, versus the conversation? I don't know the answer to that question because I've never been able to do one and not the other. There's part of me that thinks all my focus on frameworks, whether it's EPAs, RHIME, milestone, is a distraction. It doesn't matter what the framework is. What matters is the teacher having the time, the training, and the honesty and the willingness to tell you what they've observed. A second question is, what's the difference between the slope of improvement, the slope over time, we call it RHIME slope, versus the competency checklist? What is the benefit of cost of separating teachers from evaluators, which some people want to do? And finally, what is the cost benefit of all the time I, as a chair or then as a dean, had to spend on faculty development? So my takeaway message for you is simplicity leads to acceptance. Low tech is good tech. If you can't explain it simply, you don't know what you're doing. And here's a short bibliography, and I thank you for your time and attention. And I'll leave this on the screen for just a minute. Incidentally, Jason, I'd be glad to send a copy of the slides and the annotated bibliography if you wish to distribute it.
Great.
Thanks very much, everyone.
Dr. Levine, would you like to facilitate Q&A?
Absolutely. There we go. So let me see if there's any questions.
I think Joel raised his hand.
Yes, Joel, will you unmute?
Yeah, it's good to see you again, Lou. And some of us do go back to the 70s in medical school. But I want to ask you about the elephant in the room with the I in RHIME, and that is, how do we assess truly clinical reasoning skills? We understand that there's a good deal of cognitive psychology that goes into this. And the question is for those who are in the field, in the trenches, it's one thing to get a differential 1 through 3, but how do we really know the students are invoking clinical reasoning skills to get to it?
Sure. Well, let me distinguish between the observation and the inference, which underlied what Ola was saying before and a lot of what we do. RHIME is an observational scheme. For us to be an interpreter, the student must spontaneously offer 3 possible explanations for why the patient has a pleural effusion and be able to justify them. So the student says, I think this could be tuberculosis. I think it could be a malignancy. I think it could be heart failure. And these are the reasons. And my first choice is tuberculosis. For a student, they do not have to be right. They only have to be reasonable. A resident has to be right. A student we're trying to engage, because for us, curriculum is an invitation. You invite someone to your house, you treat them with respect and kindness. So you don't say to the student, tuberculosis, that's stupid. What you say to them, you're thinking, that's what we want. Let's talk about why it's not TB and is more likely to be pneumonia or pulmonary embolism or heart failure. So if a student or a resident, in fact, gets it right, their differential is correct, Joel, then I am willing to say they have their clinical reasoning is satisfactory. Now, let us say there is the syndrome is they're having trouble going from reporter to interpreter. That's a syndrome like nephrotic syndrome, and now we have to find out what are the causes. There are many different molecular causes of nephrotic syndrome. So this is when we move from the synthetic framework to the analytic framework, and we look at skills, knowledge, attitude, clinical reasoning separately. And that is a different question, Noel, and I could spend a half an hour about how I think we teach and evaluate clinical reasoning, but my focus today has been whether or not the work product of the reasoning has been accomplished. If, again, I'm going to infer if their differential is correct and they have done it on their own, they're not just simply repeating what the resident said, then the clinical reasoning process has been successful. If I'm not sure about that because they've been working closely with the team, then I would have to probe to see whether or not they could in fact justify their differential diagnosis. What's for and against TB, what's for and against heart failure, what's for and against pneumonia as a cause of the pleural effusion. So I've taken a step towards your answer rather than describing the mechanics of how we teach and evaluate clinical reasoning. I've done it at a more macro at the level of observation. I'm willing to go further if you want, but that's
good. I'm just,
that's another 20 minutes.
In this, for the interests of time, absolutely not. But that notion of are they moving from hypothetical deductive reasoning to pattern recognition? Are they going in the right pace? Is always a subject of interest.
Okay, good. Let me go further then. To me, this is a 3-step process. In the pre-clerkship period, we have the internalization of several concepts: heart failure, pneumonia, pulmonary embolism. That's the first step. Before they go to the clerkships, they have to demonstrate their ability to apply, transfer, whatever word you want, those concepts to a prototype, a paper case or a standardized patient, an actor in our simulation center. So that's step 2. If they cannot do that to a prototype in which every patient with pneumonia has a fever, every patient with pulmonary embolism has tachycardia, every patient with heart failure has edema, then they are not ready for the clerkships. So the assessment is first, can they articulate the dimensions of performance within the framework, heart failure, pneumonia, pulmonary embolism? Secondly, can they apply it to a prototype? And then they go to the clerkships, which is in which not every patient with pneumonia has fever. And in fact, they may have 5 other diseases at the same time. That process of the transfer of the concept, even successfully internalized, takes 3 to 4 years because they must see 20 to 50 cases of heart failure pneumonia to develop a rich idea. This is exactly what we see with the RHYME scheme. I can show a student, I can show a dermatologist or a biochemist a prototype videotape of a student who's a reporter or interpreter, and within 10 minutes, there will be 90% agreement. The trouble is, once you get to a real student, they don't look like the prototypes anymore. They may be an interpreter on one patient, a good interpreter on another one. They may have the pertinent positives and negatives, but not be able to articulate why. So the process to me, internalization, application to a prototype, which then helps develop through the instantiation of the prototype, helps develop the internalization. That's the easy part. That's all pre-clerkship. The transfer to a complicated real world in vivo patient, when we move from in vitro to in vivo, takes years. And so I think this is one of the reasons why at the clerkship level, to get credit for being an interpreter, which would have been in a high pass when we had a high pass grade, you just have to make sense. You have to do it spontaneously, 3 possible explanations that you justify, but you don't have to be right. So that's an example of the dimensions of performance. What do we mean by an interpreter? And I've tried to draw the analogy to the clinical reasoning process because the faculty have to do the same clinical reasoning process. They observe the learner. They can or they cannot do the entrustable activity of doing a complete history. Then they have to decide what that means. Once you have the surface observation, you can't do the task. Then you could go into KSA and say, do they lack the confidence? Do they lack the skill? Do they lack the knowledge? So, but as I've been saying all along, clinicians have this ability. We save lives from looking at messy data, and we reach the right diagnosis. This is heart failure. This is not pneumonia. We save lives. So I think they can apply these rhyme or other like prototypes given time. Thanks for the question.
We have a question from Jenna Carter. How do you talked about the next day after your conversations with the evaluators and the clerkship director having really timely feedback back to the students and focusing it. And Jenna asks, how do you improve the robustness of the conversation that happens between a director and the student or resident when reviewing evaluations? Is there room for improvement in the director helping the student or resident to identify ways of growing from that feedback? And how do you do that?
Yeah, sure. Well, there's 2 aspects to this. This is not published data, but what we have found is that once we have been at a clerkship site for a year, the students have already heard from the intern, the resident, and the attending 85% of what we have heard from the teachers. So they have started to develop feedback skills, the teachers themselves. So the student has already begun to process some of the feedback even before they sit down with the clerkship director. The job of the clerkship director, just as you would with a patient, is to begin with an open-ended question. What are your symptoms? What have you heard? What meaning do you make of it? And then the clerkship director has to work with the student to prioritize. One of the problems we have is the intern's priority feedback for the student may be, you have to be here until 8 o'clock at night to help me with my scut work. And the attending's priority may be, you need to read the New England Journal and come in the morning and teach me what the journal says. And the real goal is to go from reporter to interpreter. So one of the things the clerkship director has to do is to first elicit from the student what sense they've made of what they've heard. And then secondly, to try to prioritize, because we have to anticipate the summative framework at the end of the clerkship, whether it's 3 weeks or 6 weeks later. And so that's my answer to the question about how to do it, is the clerkship director has to be themselves developed by the education system, that's that 3rd level, in order to do their own calibration of the teachers and their discussions with the students. It takes us, first thing we do is we pick teachers who have the personal attributes that were referred to before by Ola and others of patience, ability to listen. And then we work on the analytic skills to help them work with the students. Very interesting subject. If you want to send me an email, I'd be glad to have a phone conversation with you next week about how we try to do this. The critical thing for me is that the teacher sits down with the clerkship director on Wednesday, and on Thursday, the clerkship director sits down with the student. What have you heard? What meaning do we make of this? Because we have to work on this for the next 3 weeks. And for me, the magic is not in the rhyme jargon or any other jargon. If there is any magic, it's in the conversations. It's in low-tech stuff, face-to-face conversations between teachers and students. I'm trying the best I can to preserve the human core of our discipline. When our dean paid for about $100,000 for an electronic medical system to ask me what I thought of it, I said it's the biggest setback in medical education in a decade, because people have always whipped the form. What makes you think they're not going to whip the form on a cell phone? In fact, the evidence is that they do that. I don't think that's inevitable, that it has to happen, but you have to build a whole culture of feedback before the cell phone or the papers are going to work for me. People are just too busy, and you got to look in their eyes and see how they're feeling about the student. We're just beginning to do studies now on, we've looked at the difference between men and women grading through the eval sessions. We're about to look at the differences in ethnic or racial differences. We're trying to actually get an inter-school study to be able to use these face-to-face conversations to detect and mollify or ameliorate or mitigate any implicit biases. And I don't think that can be done with a piece of paper or a cell phone. I think it only can be done in person.
But we can certainly introduce biases in the narrative as well. I want to introduce one last question, and that is, we learn that structure determines function. And you mentioned electronics, and I'm just going to mention the electronic health record, which I think is destroying, personally, our students' ability to reason, as mostly they are describing what happened, documenting and reporting more and more, rather than interpreting and managing patients. Notes become as long as they become incredibly long. Do you have any recommendations or insights about how we might modify the requirements for a note to include things, like you said, list the differential diagnosis and what goes for and against?
Yeah, I don't think I know any more about this than you do, Diane, or Joel or Ola or anyone else on the call. I could give you a lot of recommendations for how to do it. Let me mention something about conversation, which is important to me. When we first had the electronic record and it hit us in a big way, this is 10 to 15 years ago, we forbade students from cutting and pasting notes from one day to the next. We said, you're not a reliable reporter if you do that. And through our conversations, these weekly formal conversations, we learned that the house staff was really pissed off at us for saying that, because they did it all the time. So we had to reformulate the dimension of performance of reliable reporter to say, you may cut and paste, but if there's something wrong in what you've cut and pasted, you own it. You own the accuracy of that information. And I'm using this as an example of conversation theory, which derives from Gordon Pask and the Brits in the 40s and the 50s about how computers work. The ability to, we modified our own internal model, mental model of what a reporter was based on the feedback from the house staff. Because we were too old. We all grew up in writing notes, and we didn't accept that you could cut and paste. So I think one of the virtues of the eval system that I'm talking about based on conversation is that you hear things you didn't want to hear that force you to change your ideas. And then you could move towards a way of talking to the house staff and the students about how can we document your clinical reasoning, what's for and against a diet. Incidentally, we have a lot of forms for students to fill out. We have an exam of analytic ability. We have forms for heart failure, what's for it, what's against it. George Bourdage years ago told me to add the statement, what is the most important fact that, and do you think it's definite, probable, possible, or unlikely? We have ways of doing this, but we're talking about capturing it. And I think that the conversations will enable us, by working with the students and the student leadership and the house staff and see what they're doing, to say, what is a good way to do this in 2021 that we weren't doing 10 or 20 years ago? So my answer, I'm sorry, is provisional, and I'm sorry it's so wishy-washy. I don't know.
Jason?
So thank you for that, Dr. Pangara. I'd like to
Okay.
really thank both Drs. Ola Tankata and Lou Pangaro for their presentations today. I think it's really highlighting the importance of the medical education process across the continuum. With that, I would like to turn it over now to Mr. Robert Reeves and Ms. Jenna Carter for our awards announcement.
Hi, everyone. Well, first off, I want to say thank you so much to our keynote speakers. Your presentations were very insightful. In addition to that, I also want to say thank you to our oral presenters, our poster creators, and also those who judged both the oral presentations and the posters. At this time, Jenna Carter and myself, we are going to present the award winners for the oral presentations, for the posters. And once again, I just want to say thank you all so much. In our eyes, you're all winners. With that said, I'm going to pass it on over to my partner, Jenna Carter.
Thanks so much, Robert. Yeah, and I reiterate everything Robert said. It was amazing to hear everything today. Okay, so for our poster awards, we're going to start with research completed works. In first place, we have incorporation of handoff procedure training into undergraduate gross anatomy curriculum could improve learning and clinical preparedness.
1 second. One second, sorry.
No problem. Okay, and in second place, we have learning community impact at a large urban university. And in third place, we have comparison of in-person and virtual gross anatomy lab instruction of first-year medical undergraduate cohort amid the COVID-19 pandemic. Congratulations to all our research completed work posters. And then next we have the research work in progress category. Our first place poster goes to a standardized patient model to empower medical students to care for patients with a visible disability. In second place, we have the role of gender in mentorship preferences of medical students. And in third place, we have the impact of peer-assisted remediation on at-risk preclinical student performance. Congratulations to all our authors who worked on the research works in progress posters. Next, we have innovation completed works. Our first place poster goes to mandatory wellness via Zoom, the structure, process, feedback, and glimpse of the larger plan. Second place goes to medical comics, a vehicle to explore humanism and reflection in medicine. And third place goes to evaluating the effectiveness of an online practicum to cultivate confidence in conducting a quality improvement project in medical students. Congratulations to all our innovation completed works. And then we have innovation works in progress. In first place, we have the impact of the ARI program on medical student perceptions on children with disabilities. Second place, we have fostering wellness and community medical student attitudes about virtual journal discussions. And our third place poster goes to the implementation of multi-segment mixed synchronous asynchronous patient safety and quality improvement subcurriculum for first-year medical students to improve clinical preparedness. Congratulations to all of our authors.
All right, thank you so much for that, Jenna. And once again, congratulations to all of the poster winners and the authors. Next, we will present our oral presentation winners. There are 4 categories. The first category is learning and teaching in medicine. This is a work in progress, and congratulations to the group responsible for using medical models to advance clinical reasoning. Congratulations to all the authors for that presentation. The next category is undergraduate medical education, work in progress. The first place winner is development of longitudinal medical ethics curriculum for pre-clerkship and clerkship training. Once again, congratulations to all the authors who've worked on this work. The next category is education in the clinical environment. This is also a work in progress. The first place winner is a multi-institutional survey of e-cigarette documentation and electronic health records and resident physicians' attitudes towards e-cigarette usage. Congratulations to all the authors on your work. And last but not least is the medical education category. The first place oral presentation is medical ventilation training of pulmonary critical care fellows during the COVID-19 pandemic. Congratulations to all the authors and congratulations to everyone, all the oral presenters and the authors of those works. Thank you so much. We would also like to recognize our faculty through Faculty Mentor Awards. The first faculty we would like to recognize is Dr. Levine. Dr. Levine, thank you so much for all of your work with our student body on the research projects, both poster and oral presentations. We certainly appreciate all that you do. We would also like to recognize Dr. Walker, Dr. Paul Walker, for his contributions to student and faculty research as well. We certainly appreciate all that you do for the medical school and university, Dr. Walker. We would also like to take a moment to say thank you to Dr. Eva Wainio and recognize her for all of her contributions to student, faculty, and staff research here at the medical school and also in the medical education community. And last but not least, we would also like to recognize Dr. Jennifer Mendez for all that she's done in terms of research and working with our students, both in the Detroit community at the Wayne State Medical School and also in the medical education community. Once again, congratulations to all our winners this evening and all of our award recipients. We truly appreciate all that you do.
And thank you, everyone. We owe a special debt of gratitude, or we're indebted to another group of people, the kind of our stars behind the scene. I would like to a special thank you to Matt Guerin, Stephen Pierce, Mike Crimmins, Susan Hanchett, Philip Van Hewley, and Delashonda Crease. These are the individuals that really kept this going along with Robert. It was conference is truly a year in the making. And in fact, next week we start on next year's conference, which will be, write it down, it will be December 6, 2022. I will be sending out a series of emails with that following the conference today. I would also like to point out that we, starting last year and continuing this year, and I will share my screen, you will find in your pamphlet brochure for the conference that has all our abstracts, the backgrounds to our speakers, is Wayne State University School of Medicine, as part of our efforts to continue and promote medical education research, both here within our institution and globally. We also put on a monthly workshop series as well, in which we highlight various topics of interest to developing scholars. We're really looking at multiple stages for those that want to get interested in medical, that want to get started in medical education research, for those that are already in there but want to take their projects to the next step. We've listened to you as scholars of what you need, and we've built these workshops out around these topics. If you have any special interest in collaborating with us to offer these workshops, just reach out to me. We'd be glad to work with you. With that, I would like to give the final comment to our planning committee, which consists of Ms. Jenna Carter, Dr. Diane Levine, and Dr. Senthil Rajasekaran, along with Mr. Robert Reeves.
I want to thank you for your leadership, Dr. Booza. I know this is your brainchild and you really nurtured it so well. And I just cannot be more proud to be associated with this initiative. I know I didn't contribute as much as I wanted to, but this session was just phenomenal. The quality of sessions that I was a part of in oral presentations, our students are doing such groundbreaking things that are impacting real lives. They're not doing it for their CVs, really. I could see that it's coming from their heart, and they're just so much of love and passion in what they do. I'm so proud to be part of this initiative, and thank you for your leadership in highlighting this and giving our students a forum to present this. And I want to congratulate all the poster winners and those who did not win any prizes as well. You did equally neat work. It's just this course didn't add up. That's all it is. It doesn't matter. You should be proud about your work, really, because every presentation that I was part of today was really, I had nothing but absolute sense of pride that I'm part of this institution. And thank you for everything that you do.
Thank you. Ms. Carter, Mr. Reeves, Dr. Levine, do you have any comments for our participants?
Just want to emphasize there will be an assessment of the program that Dr. Booza will send out. Please look forward to getting an email with that, and we hope that you will fill it out so that we can do continuous quality improvement in education.
Yes, thank you for that reminder.
Yeah, I come away from this day being so impressed and like inspired by my peers and faculty members, and seeing how much everybody really works hard, all the time to make improvements. And I think it's just, there's some really amazing things that were presented here today. So I look forward to next year's. And I also wanted to encourage everybody to take a look at the workshops that Dr. Booza and Dr. Levine and Dr. Radisakran have worked hard to kind of outline for everybody, because there's a lot of follow-up steps from this where you can take work you've done here and take it to the next steps. And there's a lot of support to do that. So definitely check those out. They're very useful workshops.
I just want to say thank you once again to everyone who's contributed and to this conference, both all the staff in the background, all the student and the faculty, and the staff members who presented either oral presentations or poster presentations. But I also want to take this moment to say thank you so much to Dr. Booza, who's really put so much time and effort into these conferences over the last 3 years. This is our now 3rd annual Mary conference, and each year it gets bigger and better. I'm looking forward to next year, and we'll see if it's going to be in person or hybrid. Fingers crossed, in person next year, hopefully.